Hi, everyone. Thank you so much for joining this session. I'm really honored to be here today with this team and to talk about um, something that I'm very passionate about, which is youth who use substances. A little bit about me. I'm a pediatrician by training and a specialist in adolescent medicine. So I only work with youth almost exclusively, and an addiction medicine specialist. And so I have the opportunity to work in this space and try to understand what we can do to address some of the issues that we see and make everyone's lives safer and better. The learning objectives for today, we're going to talk about some differences between adults, young adults, and adolescents. And these terms sometimes don't have very clear definitions in terms of age. We're going to describe some screening, diagnoses, and treatment, and some barriers and opportunities as well. At the end, I really want to highlight the Youth Voices report, which I think is very important to encompass the voices of the youth who are serving. It's a lot of content, so I might not read through every single point on every slide, but please feel free to look back at the recording. So here in BC, we know that youth, here defined as 15 to 24, are quite affected by substance use. We have 68,000 youth who might meet a criteria for a disorder, and there's even more who might engage in higher risk substance use that don't meet the criteria for a disorder. So if you think about how large a typical high school this is 60 high schools that are affected by substance use disorders. Um, we know that there's a lot of gaps, not just in resources, but also in clinical treatments, research, and so on, and in funding. And specifically, when we think about youth, oftentimes when we don't have the research, we are extrapolating from adult knowledge and how we treat adults with substance use disorders. And oftentimes that's not always the most effective. Youth in particular, we have to think about brain development. It's a period of time where there's a lot of change, not just in the body, but also in the brain and also in the social context and how youth move through the world. We know that there are stereotypes of what youth who use substances typically engage in or what they're like, but some of these can be really harmful stereotypes. And we know that youth who use substances are a very diverse group and can affect anyone from any walk of life. It can affect things that are really important to them, like their friends and their school and their vocation, and it can lead to further problems later on when they are in adulthood. This is a clinical care pathway that I had the pleasure of working on with the UBC Continuing Professional Development Division, as well as with Doctors of BC Shared Care Committee. This is trying to really crystallize our thoughts among those of us who work in youth substance use on how we can approach youth when they come into our office or when we see them and try to provide care. What are the key components and what order should we go about them? So this is kind of our expert consensus on how we might approach it. And you can find a full version of this in the resources as well. This has been distilled into this very neat flowchart talking about opening a conversation, screening for use, screening for concurrent conditions. So this would be like mental health conditions like anxiety, depression, PTSD. Um, and offer education, determine goals, and identify current supports as part of the conversation, which are interchangeable. Then identifying what's missing, what team members are still needed for this youth, and how do we get to them? Do we need to do a referral? So this is kind of the flow that our visits tend to go in. And of course, there's going to be variations depending on the individual. Uh, when we think about developmental stages, this is another important consideration. The World Health Organization defines adolescents and youth in a very broad range, from as young as 10 to as old as 24 or 25. And, a 10, 11, 12-year-old is definitely not the same as a 22 to 24-year-old. There's going to be differences in cognitive ability, the ability to understand and reason, as well as the relationships with the people in their lives. So an early adolescent is really thinking very concretely. Things are typically, are very immediate. A middle adolescent is starting to develop that abstract thinking, but still very much values peers and peer influence as a big component. In later adolescence, we're starting to see more individual thinking, more abstract thinking, starting to manage some life skills. And then a young adult should be able to engage in abstract thinking, compromise, and manage themselves independently. We know that youth also tend to use substances in different patterns. They tend to use things opportunistically. They tend to use things together, or they might change from time to time. They might use one particular category of substances this time and a different one next time. And this is part of that social context of how substance use occurs in youth. Withdrawal symptoms are sometimes different. They might not know it. We might not know it as clinicians. They might not have as severe withdrawal symptoms as well. And they're less likely to hop over that barrier, the barriers of care, and really connect with healthcare. Another thing that we think about that comes up a lot in youth substance use is really where is the youth at developmentally, not just by their developmental stage, their physiologic developmental stage, but also have they incurred any injuries? Do they have any developmental disorders that might affect how we understand their cognitive ability or their ability to engage with care? There's a lot of considerations of early brain injuries affecting later life, as well as knowing that there is some neuroplasticity as well. Whereas for adults, it's kind of like what you got is what you have. It's really important to screen youth for substance use disorders, and to do so requires that invitational approach, being very non-judgmental, trauma-informed, and being very safe and humble. I think there is the sense of being an authority figure that we have a lot to tell our youth, we have a lot to teach them. At the same time, we also have a lot to learn from them and from their strengths, and their individual goals might be different from our individual goals, and that's okay. So our recommendation is generally to start screening youth as young as age 10. We know that for substances such as nicotine and cannabis, half of the youth who use those in high school have started by 13 or 14. So 10 is definitely not too young. And to think about the developmental stage, so using the right language, using maybe appropriate examples, thinking about things in their life like school rather than something that might affect an older youth like work. And the last piece is very important. We know that most adolescents with substance use disorders also concurrently screen positive for mental health disorders. Here are some validated screening tools, and I won't go into them in detail, but some ones that I'll highlight that are easy to use in a clinical setting are the CRAFT questionnaires, which is 6 questions, S2BI, which is adapted from SBIRT, that some adult providers might be familiar with, AUDIT, and QDIT. The diagnosis of substance use disorders is also a bit contentious among minors, I should say, because it hasn't really been validated. It was designed very much for adults, and so there's a potential for misclassification. So it's not definitely not just a checkbox approach. Some of the principles of youth substance use treatment, which are very, very important, are intervening early and not just responding early, but also thinking about primary and secondary prevention, thinking about how to tailor the treatment to the individual, thinking about recovery-oriented care. And recovery can mean different things and not necessarily abstinence, but thinking about how to recover parts of their life, like with their academic functioning, their family functioning, their purpose, their connection. Thinking about harm reduction, which is something I think sometimes when it comes to youth, it's a hard conversation. And lastly, to think about co-occurring disorders. There should be continuity. It's really important to youth, especially, to know who they're talking with, who their providers are, who their care team is. And in our current healthcare environment, where there's a lot of turnover, this can be quite challenging. And we should be ready to offer youth the full range of what we have, and not limit them from resources that potentially could be offered, but we might not think is appropriate. However, it's important to tailor those for youth. It's important to do psychosocial treatments. This is often the foundation of how youth can get better in the long term. In the short term, absolutely, pharmacology is very powerful. In the long term, that foundational piece, what will set them up for life, is going to be that psychosocial support. And of course, tailoring. This is just some key takeaways from the World Health Organization's UN Office on Drugs and Crime, which publishes an annual report on the status of substances and substance-related crimes in the world. And in one particular issue, they had a focus on youth. So some of the key takeaways are to offer mental health services, to think about how to engage the parents, but also to train them, not just you know, having them physically involved, but also skill building. Thinking about family therapy to heal some of those attachments, which is often a huge driver of substance use in youth. Thinking about community and school screening, so bringing in your team members, doing your brief intervention in that one-on-one interaction, and referrals. We have very limited research when it comes to treatment. And when I say limited, I really mean very limited. And part of the reason is because this might not be as high priority, or it might be difficult to research this population for various reasons. There are two treatment modalities that have consistent evidence, which is motivational interviewing and family therapy. There's insufficient evidence about what other kinds of treatments are effective, bed-based versus community. We don't know, and we should know. We should be doing high quality research on this. Pharmacotherapy is also very, very limited. For example, some very common adult medications like varenicline for nicotine hasn't been shown to be as effective in teens under 17, or another medication for cannabis use disorder, N-acetylcysteine. It's effective for adolescents, not effective for adults. And that's some of the differences that show we can't simply just use adult literature for teens. And consultation is important if it's available, but too often youth specialists are not available. And so we need to build capacity in our systems. In BC, here are some of our resources for bed-based services divided by health authority and the number of beds that number of services that are available. When we talk to youth and we ask them, what are your barriers to care? Why is it hard for you to get the things you need, or what things could the system do to make it better? And they highlighted some really important things like accessibility and wait times, that things tend to be very siloed and restrictive. One place does one thing, another place does another thing, and there's no integration. There are certain conditions that might make it really challenging for them. And so they're emphasizing the lack of low barrier resources. There's a lack of housing, employment, and income supports. So maybe a lot of it's focused just on substance use and not thinking about the individual holistically. There's a lot of mistrust, rightfully so, especially for our marginalized BIPOC youth and LGBTQ youth. There's a long history of abuse from the medical system. So we have to earn their trust, and their trust isn't just assumed at the beginning. There's a fear of breaking confidentiality. There's a lack of youth-focused resources, and youth often don't want to go to adult-centered resources. There is hesitancy around medications, which is understandable, and we don't have enough culturally appropriate resources for Indigenous cultures and other cultures as well. So here are some things, the flip side, not just looking at it problematically, but what are some of the values that should be important when thinking about designing these programs? They should be youth-oriented, they should be relevant, should be interesting, accessible, confidential, family inclusive. They should be able to offer both pharmacology and psychosocial treatments. There should be some longitudinal or relationship building, rapport building with staff, and so it isn't just a rotating cast of providers. And youth really want not a hard and fast end date. They want some flexibility. I wanted to highlight the Youth Voices report from the BCCSU, which is a focus group of youth aged 14 to 24 of a wide variety of demographics who had a summit and answered these two questions. What core values should guide the delivery of youth-focused substance use services, and what should be included in substance use treatments? And their responses were turned into infographics, which I think is awesome and beautiful. And it's such a neat way to understand the stories that are being told and the advice that we're receiving. So the youth highlighted values such as being non-judgmental. There's already enough shame for them in their lives, and for them to be able to reach out and get to where they are, they've had to overcome a certain amount of shame. So having more will just push them backwards. Being individualized, seeing them as an individual, not just as another disorder or another person on the list. Being trauma informed, understanding their life experiences and what they've gone through. Being culturally informed, knowing what culture means, and saying things that would be sensitive and not hurtful, and forcing them to feel like they can't open up. Being confidential, this is also another really key piece. Holding confidentiality and trust, inside within the limits of the confidentiality that you're able to do is very important. Youth are understandably afraid of police, or afraid of sometimes punitive parents or other family members, afraid of social workers in the ministry, and so on. It's important to have informed consent and to not do things against consent just because they're youth. It's important for it to be accessible. This includes the hours of opening, being open later, being open on times when youth are not in school. And when we're reimagining what a substance use system could be like for youth, it will really emphasize that connectivity, that multidisciplinary involvement, the social connection, the things that are important for their lives, like friends and housing and academic or vocational achievement, recreation, culture, harm reduction, safe supplies, and then having that wide variety of outpatient, inpatient, detox supports. Here are some key recommendations from the Youth Voices report, which I'll read out. Center relationship building, self-determination, and safety in treatment and care. Presenting pharmacotherapy or medications as one piece of a whole that includes housing, employment, income, social, and cultural supports. Seek permission before sharing information about youth with other providers. Focus on the present, not the past. Involve youth as partners in developing plans and timelines for OAT, or opiate agonist therapy, and psychotropic or psychiatric medications, including pathways to taper, so they know what to expect. Avoid approaches that privilege monitoring surveillance, which can signal danger to youth and lead them to disengage with care. Recognize that many youth prefer treatment modalities that give them more control and subject them to less surveillance, and acknowledge the use of cannabis as a treatment and harm reduction strategies. So this is what we heard from the youth. So it's important that we empower them. It's important that we have shared decision-making, that we think about where they're going in their futures and how we can help them really attain that dream of their best self. How can we deliver these treatments alongside other environmental or psychosocial treatments like housing and employment? How we can use a medical model that doesn't just focus on surveillance and monitoring, and how can we help them grow their self-determination and become more independent? So a summary of what we talked about today. One, youth require specialized care and approaches. Teens and adolescents and young adults are not the same as middle-aged and older adults. Now we have to consider their developmental stages, and we have to tailor it for that developmental stage. We have to regularly screen and take extra effort to build rapport and to maintain that rapport. And we have to be extra conscientious about autonomy, confidentiality, as well as the limits of those, and trauma and violence informed care. So that way we can build a comprehensive system that includes medical services, medications, psychological services, and support with their environment. Here are some resources that are helpful. The Foundry Virtual Clinic for Youth, if youth do not live in an area with an accessible Foundry Youth Hub. There's an OAT line, and for healthcare providers, accessing the RACE line to talk with a specialist. The Compass Mental Health line at BC Children's Hospital, which is up to age 24, run by Child and Adolescent Psychiatry for provider-to-provider advice. The VCH Youth Substance Use Services site, and the BC Child and Youth Mental Health Substance Use Resources through that pathway that I showed earlier. Here are my references, and I will hand it over to our facilitator to moderate questions.